Hello, doctor.
Hola, Uriel. Hola, Maria. Margarita. ¿Está allá? Sí, Margarita, hola.
Margarita, yes, I'm Margarita. Now,
¿Está bien? ¿Está bien?
todo bien, ahora
Okay.
sí.
Ok, ahora sí, ok.
Oh,
Sí, estamos empezando un poco lento, pero está bien. Tenemos tiempo para recubrir.
perfecto.
La término lateral, la terminal la que menos usás, ¿no? Realmente la que más se usa es la término lateral. La terminal y terminal la usás. La terminal lateral es como una terminal terminal.
Hello.
Es como para recordar. Encima tienes tensiones, es como ya más distinto tienes tensiones. Cuando se tiene el punto desaparece la tensión, cuando se sube el talón.
Hello, Ahmad.
Hello.
Hello.
Hello, sir.
Welcome.
How are you?
Welcome.
No, todavía no. Es que le he retrasado.
Hey, Ahmad, stay around
Yes,
after.
hello, sir. Hello,
Stay
thank you, Professor John.
Yeah, stay around after. We're going to meet in the lounge after the meeting, okay?
Yes, yeah, please.
You can come in and meet some students and maybe meet the
Esta
presenters too.
mañana no te sé decir.
Yeah,
Hace 3
we
días.
will discuss
había un
for
documento escrito.
next
Yo
time, yeah?
cuando he mirado después de todo.
Yeah, it's another Zoom. I'll give you the address at the end.
¿Sabes?
Okay,
Vamos a
we
ver
will
cómo-
come.
cómo
Yes.
Okay, good.
¿sabes?
Yeah, okay, thank you, sir.
Okay. Okay, I'm making a co-host, for real.
Okay.
Hmm.
Pues acá. X. 20 Nasıl ciri kuruyor? Evet.
Okay, Margarita. Who was the first speaker? Margarita?
First ones will be Dr. González Llanos.
Oh, okay, Dr. González Llano, okay. En inglés, ¿verdad?
Pero bueno, pero soluciones que las tienes porque las tienes que aplicar.
After him will come Dr. Mura.
Okay.
¿Está doctor Muray o qué?
No, todavía no. Usted tiene que estar en un minuto.
¿Yo?
Sí.
Okay.
Ya has grabado el vídeo, espera nada.
Doctor Rubino.
¿Sigo ya?
Sí, para mirar por la puerta.
Ok.
Es que me va a llamar.
Pero no salgo yo, porque
No,
si
no.
salgo no te puedo entrar.
Pero sal por la de emergencia.
No sabe poner la piedra.
Ahora voy a que me voy. Ah, pongo una piedra.
Vamos a la charla.
¿Está conectado?
Vale, tengo que traer el aquí. Lo metemos aquí, ¿no? Venga, mañana nos vemos. Muchas gracias. Nada, aquí. A ver.
Estaba todo perfecto, doctor.
No, si lo he minimizado solo.
vale, vale.
Tengo que buscar mi charla. A ver, espera ahí.
Ah, Idris, you came in. Okay, Idris from Iran.
Ay, yo tengo el sonido al 100%. Se ve muy bajito.
A ver, vamos a ver. Uy, a ver si me deja. Si lo metemos a Mura directamente. No puedo creer que con este no puedo entrar. ¿Qué te parece? Eso es porque es la última versión de esa mierda, ¿sabes? No me deja.
Ah, porque es que yo tengo un sistema atrasado de Windows.
Ya. A ver si me deja.
Margarita?
Tell me,
Margarita?
doctor. Tell me.
Margarita, después de los charlas, tenemos un lounge, un Neurosurgical TV lounge, después
Sí, que tiene.
de los charlas, ¿ok?
Ok, but.
Yo voy a dar otro link.
What should we do
al
in
fin-
the... Yeah.
o solamente yo voy a dar un link al fin de los
A ver,
charlas
a ver.
para invitar a este Zoom o otro Zoom, ¿ok?
Responde. A ver, espera, espera.
Yo voy a explicar al fin de los charlas
Vale.
antes de cerrar, ¿ok, Margarita?
Ok.
Ah, vale, la ha cagado. A ver, espera, vamos a ver si lo corre. A ver los vídeos, a ver.
¿Quiere probar algo?
Sí, let me check if I can.
¿Quiere probar
Okay,
algo?
okay.
Doc?
It's okay. A ver, y ahora le damos a compartir pantalla, ¿no? Ok, let me check. A ver. Ok. How do you have this? It's okay.
Sí, bien.
Jim. Okay.
Bien,
We are
voice,
sharing
bien.
the screen.
Okay.
Okay. Hello, I'm Dr. González Llanos from.
No, wait, espera, Doc. Déjame empezar a grabar.
Okay.
Necesito grabar. Ok, tú estás listo, obviamente.
Yeah.
Ok,
I'm ready.
10, 9, 7, 6, 5, 4, 2, 1. Buenos días, soy Dr. John Bennett, televisando para Neurosurgical TV. Tenemos un placer de tener González Llano, un neurocirujano de Madrid, del Congreso, Conferencia Internacional de Microneurosurgería Vascular, Tumores y Base de Cráneo. Bienvenidos, Dr. González Llano.
Okay. Hello.
I'm Dr. Gonzalez Llanos, Chief of Neurosurgery of University Hospital in Toledo, working in Toledo and Madrid. And I would like to share with you a lecture on complex aneurysms. To define a complex aneurysm, we should ask ourselves three questions. What is a complex aneurysm? For whom an aneurysm is complex? And how should we deal these complex aneurysms? And I would like to review with you a bit of history of neurosurgery. And the first concept is that the complex aneurysms, the concept itself of complex aneurysms is dynamic, changes with time. If we step back to the 19th century, in 1885, Victor Hosley was one of the first, reported one of the first cases of complex aneurysms at that time. And he defined a large blood cyst, he called it. And he found in an aneurysm comprising the optic chiasm. And what we did was to ligate both cervical carotids. Surprisingly, the patient died years after the surgery. So probably this patient had a very good circle of Willis. Then in 1929, in the 20th century, this giant of neurosurgery, Harvey Cousin.
Con permiso, doctor, tú no estás compartiendo sus slides. You're not sharing, yeah.
Yeah, excuse me.
No
we should share let me see if we're
okay.
Checking. Let me see if we have. Let me see.
Ya no.
Let me share the llama a. No estoy compartiendo pantalla. A ver. No, a Alexis. A ver por qué no comparto pantalla.
A fondo compartir.
Let me no. It's okay. Let me share. Now let me see if I'm sharing the screen. Maybe this one. I don't know what. Pizarra, esa está la pizarra, a ver.
Estaba empezando, sí. Tú puedes
Okay,
ver, ¿verdad?
let me check again.
Okay. No está abriendo la fila.
A ver, estaba haciendo la presentación perfectamente. Sí. A ver, no, ahí estamos. A ver. Vale. Let me see now. Am I sharing the screen now?
Sí, comparte la fila. Abre la fila.
Is it okay now?
No, abre la fila. La fila no está abierta.
No está abierto.
No, la fila no está abierta. Ábrelo.
En compartir pantalla, ok. This.
Abre la fila primero.
Ahora dale aquí.
SOS.
Now it's okay.
Sí.
Is this okay?
Sí.
Okay. As I said, to define a complex aneurysm, we should ask several questions. What, for whom, and how? I told you. And we go back to check the history of aneurysm surgery. The first reported, Victor Hosley treated aneurysm, used the ligation to treat probably what was a huge ACOM aneurysm. In in the beginnings of the 20th century, in 1929, Harvey Cousin was operating on a pituitary case, and suddenly in the surgery, he thought it was a pituitary cage, and the patient had an uncontrollable bleeding. Probably was the first attempt, without knowing, of treatment of a paraclinoid aneurysms. Unfortunately, this patient died.
The slides are not changing. You need to change the slides.
Yeah, now they are changing now.
No, está la primera. It's called la primera slide.
Okay,
ahora.
okay. Now it's we're still in the first slide.
Sí.
No, but I'm changing the slide here. Let
No.
me see. Let me see.
Okay.
Maybe is this.
Sí, vaya al fondo. Al fondo hay opciones de icons. Hey, SOS.
This one.
Sí, it's Harvey Cushing. Sí, Wilhelm Magnus.
Yeah, Wilhelm Magnus, the next one. Let me see. Now, are they changing now?
Sí.
Okay. So Harvey Cousin was the next to feel what complex aneurysms are, trying to operate on what he thought was a pituitary case, but in the end it was a paraclinoid aneurysms, and the patient died. They didn't use angiography at that time. In 1924, this is very interesting, Wilhelm Magnus, a pioneer of in Norway from neurosurgery. It's in Norway, he could be like the Cushing of Norway. No, this guy was operating a trigeminal neuralgia via a subtemporal route, like the way they used to do that at that time. And the patient had a massive hemorrhage, probably from an intracavernous aneurysm at that time. This case was controlled with cervical ligation, and the patient did well. In 1928, Walter Dandy treated his first aneurysm with a cervical carotid ligation, again, like Victor Horsley. But this is the breakthrough in aneurysm surgery. In April 1931, this great guy, the Norman Dodd of Edinburgh, performed the first direct approach to an aneurysm. Look at that time. He performed a right subfrontal approach to the basal cisterns, and the patient had a MCA aneurysm. It's not, of course, the best route to deal with this kind of aneurysms. The patient bled during the surgery, but he controlled the bleeding from proximal to distal in the sylvian fissure by wrapping the aneurysm with muscle and with compression for 12 minutes. The patient not only survived, but was practicing sports several years later. Was the first wrapping on an aneurysm and successfully treated the aneurysm. Later, another giants came, Olive Krona, of course, Drake, Jassargill, Schund, Spetzler, and now these guys, Michael Loudon and Rokuya Tanikawa. A lot of people had evolved the treatment of the aneurysm. So the first question, what is a complex aneurysm? If we ask this question to Norman Dodd or to Victor Horsley, they were giants of their times, but they would have answered in a different way than this last generation surgery. So it's a dynamic concept. What today is complex, tomorrow could be easy in neurosurgery. An objective definition of a complex aneurysm, it's an aneurysm that is difficult to treat without risk to the patient. And again, it's a dynamic concept. What is complex today might be not complex even for us tomorrow. We look over the principles of any vascular microsurgery: clean anatomatic dissection, control, proximal vascular control, and management of the perforators. These are the three pillars of our surgery. As long as you are able to control these three issues in your surgery, you are about to succeed. If you don't have the control of these three pillars of our surgery, your patient could be in trouble. The first thing we need to learn it's how to dissect the sylvian fissure. ¿Cómo lo paso esto para que pase, Pablo? I don't know if I can run the videos. ¿Cómo lo hago para correr el vídeo? No corre. Aquí, hay que darle aquí, ¿no? No aparece nada. Eso es que no ha cargado bien, ¿no?
It's moving, but slowly.
Ah, it's moving slowly.
Yeah, well,
me see now.
stop,
Okay.
stop now, stop now.
Maybe it's probably here. No, pasa. In Apple sigue. Bueno. Okay, I can run the first thing we have to know how to deal with is to be able to open very carefully all the cisterns and deal with the vessels. This is the intracranial part of our surgery. This is the beginning to start treating with complex cases. Then we have to learn other tricks. What is the definition of a cerebrovascular surgeon? What makes the difference between cerebrovascular surgeons? The anatomical knowledge, the microsurgical skills, and experience. There's three pillars to tell the difference between the surgeons. You can be more sympathetic or an ugly guy, whatever. But the most important things is the anatomical knowledge, the microsurgical skills, and the experience. This is what makes us different. And why is an aneurysm complex? The size would be the most independent important factor to define an aneurysm as a complex one. Then the second would be the wall quality, because some of them might have calcium, or they are blister, or many things. The wall quality is very important too. And the third important issue is the location of the aneurysm. It's not the same as the aneurysm is in a very shallow area, or is much more complex if they are deep. But as an independent factor, the most important factor would be the size of the aneurysm. What do we need for the management of complex aneurysms? The first thing is the vascular microsurgery domain. We have to master the vascular microsurgery. You should be able to navigate all the cisterns to deal to treat all the vessels very gently without damaging them. The second important thing is the mastery of the skull base. Why? Because in order to gain proximal control and in order to respect the brain and the vessels and not to retract anything, we have to work in the cranial base many times. So we have to master the cranial base. If you want to be a cerebrovascular surgeon nowadays, you have to master the skull base too. And then there is a commitment. If you want to become a cerebrovascular surgeon, a truly cerebrovascular microsurgeon, you have to be a commitment with physical and mental work. Then another question: are rupture aneurysms complex? In the late years, we've seen a movement towards the endovascular, and fewer and fewer aneurysms are treated microsurgically. We feel that the microsurgery is a very safe treatment for ruptured aneurysms, and in the end, if you are used to deal with these aneurysms, they are not complex at all. They have their own technique. You have some advantages and some disadvantages of operating the aneurysms in You don't see the video running, no?
Let me see, Doc.
I can run the video. I'm sorry, but then we will define different techniques for microsurgery technique for complex aneurysms. We have the clip reconstruction for in complex aneurysms. In large aneurysms, we seldom can a single clip an aneurysm. We need reconstruction with several clips. And we need the careful handling of the temporary clipping, because these complex aneurysms are more difficult to reconstruct, and we need to master the temporary clipping. And then the clipping strategies, that are very important. Now we have a lot of new clips fenestrated with different angulations, and it's very important to master the different clipping strategies. We should have a strategy beforehand, and then we adjust our technique to in the operative scenario, but we should have a strategy before going to the OR. And then the bypass. The bypass is a weapon we have to treat to deal with complex aneurysms that makes the treatment safer. About the cranial-based approaches, of course, we should master the far lateral approach mainly for pica aneurysms. We should master the CPA, the retrosigmoid approach for CPA, for ACA aneurysms, and some mid and low basilar aneurysms. And then we have to master the cavernous sinus. This is a Fukushima drawing of the triangles of the cavernous sinus. We should master the transcavernous approaches for many cases. We use the middle fossa approach, the pretemporal, the subtemporal. Now we're using the Mi Plata approach of Dr. Mura, transcavernous, combined with mini-terional. Sometimes we can use the subtemporal or middle fossa, like in this case of SCA bypass, in this superior cerebellar aneurysm. So we have to master all the approaches. But it's very important the mastery of the clinodectomy. These are because the clinodectomy is key for the treatment of the paraclinoid aneurysms. You know, the paraclinoid aneurysms, there is some controversy nowadays. Some people think they should always be treated endovascularly. We don't feel the same, because many times the compression, the optic nerve compression is an issue. And in all that cases, we can release 100% of the compression to the optic nerve by surgery. With these aneurysms, we can reduce them to 3 groups of aneurysms. Some of them point superiorly, 3 or 4 groups. Most of them point superior medially. These are the ophthalmic, the true ophthalmic segment aneurysms. Some of them point medially, the carotid cave and superior hypophyseal. Some of them, some transitional laterally, and some ventrally. We will see. There's always an endovascular option. Of course, we can carefully discuss the case with the endovascular guys to see the better option. And the most important thing in these aneurysms is to preserve vision. We have to protect the optic nerve. We think that surgery can help in protecting the optic nerve. And the second important thing is the pituitary function, because we can't forget that the superior hypophyseal arteries are very important in the blood supply of the hypophysis and the stalk, and we have to preserve them. Very important. Here we have the traditional again with Fukushima model, naming the segments of the carotid. There are several ways of naming the segments of the carotid, but it's always the same. Here we have a segment from the proximal ring to the distal ring. This is the clinoidal segment. In this classification, the C3, the one I use. And we have this segment from the ophthalmic artery to the PCOM. This is the C2 segment. No matter how segment you use, but it's always the same. Big, large aneurysms in this C2 segment end up involving the C3 segment, or at least they need the exposure of the C3 segment sometimes for proximal control or for clipping. So this is our work zone with these kinds of aneurysms. This is a very important paper for the last years by Dr. Mura and Rafael Martinez Perez and all the team, reducing the groups of paraclinoid aneurysms we have. Sometimes we tend to think that are a lot of different types of kinds of paraclinoid, but in the end, the most frequent is this, the pure ophthalmic, projecting superiorly. Then we have these two, the number 2 and number 4. This is the carotid cave, the proximal, and the distal, the superior hypophyseal. And then we have this lateral one. These are very, the carotid cave and superior hypophyseal are very dangerous for the vision of the patient when operating them. And probably the carotid cave are less prone for bleeding. So sometimes we are more conservative with this kind of aneurysm. Finally, we have this lateral transitional aneurysms, very dangerous because when you drill the anterior clinoid, the aneurysm is just below the anterior clinoid. And then we have more distal in the C2, we have a ventral and a dorsal. And this would be the dorsal and the ventral, one superior and one inferior. Many times these huge aneurysms involve also a part of the C3, or at least you need exposure of take out the anterior clinoid and the exposure of the C3 for proximal control. Here, unfortunately, I don't know the reason why. These are the landmarks, the distal ring and the proximal ring. Once we take out the anterior clinoid, the proximal ring, the distal ring, excuse me, would be just inferior to where the medial size of the clinoid was. This is, it's unfortunately, I can't run the video. I had some videos for you here. One of the carotid cave aneurysm. Here we can run the video. You see medially and proximal to the ophthalmic artery, broad neck. And in this case, we decided to clip the aneurysm. In this case, we have to widely open the distal ring, and besides, we need the use of a fenestrated clip in these aneurysms. Unfortunately, I can't run the video. I'm so sorry. We use a mini terminal aneurysm for this case. This would be the second type of paraclinoid, the pure ophthalmic aneurysms with the superior medial projection. In this case, probably these are the easiest one to treat, almost always distal, or even including sometimes the ophthalmic artery, but they're just distal to the ophthalmic artery. Can be treated with a mini terminal, with of course anterior clinoidectomy and peeling and everything, but with 1 or 2 clips, just opening the distal ring. These are the easiest one, depending on the size, of course. Sometimes they are giant and they are very difficult too. And this would be the lateral transitional. For me, the most difficult to treat because they are just below the anterior clinoid, that are more difficult. They are partially, many times they're partially intradural, they are partially in the clinoidal segment and partially in the inside the in the subarachnoidal space. So we have to many times reconstruct this very carefully. And we need again a wide opening of the distal ring. In the end, to sum up, to treat the paraclinoid aneurysms, especially these main three kinds of aneurysms, laterally, medially, or superior, you have to master the opening of the distal ring. and the exposure of the clinoidal segment of the carotid. You have to master that. And it takes time. When we start operating on these aneurysms, we're not experts from the beginning. We are more reluctant to be aggressive with the distal ring at the first. But in the end, you realize that if you control the thing and you have, we almost always control the cervical ICA in the neck. If you take all the protective measures during the surgery, you have a good plan, and you master how to deal with the distal ring, you are able to treat almost all these aneurysms. The second thing to discuss here is the reconstruction with clips. When? Now we leave aside the paraclinoid, and we're talking about aneurysm in general. When do we need reconstruction with clips? In large aneurysms, and in some small but complex aneurysms, we also need reconstruction with clips. But especially we use the clip reconstructions in large aneurysms. And the goal in large aneurysms is to minimize the temporary clipping. We put a pilot clip at the beginning of surgery that allows us to remove the temporary clipping, and then we go on with the reconstruction without temporary clipping. You gain this with experience. You gain confidence, and you are able to treat better these aneurysms when you gain experience. In the end, with more experience, you end up having very shorter clipping occlusion time. And then don't forget about the prophylactic bypass. When we try to reconstruct an aneurysm and we don't know for sure how long it's going to take us, especially in very large or complex one, or when the quality, when the aneurysms have calcium, because if a large aneurysm has calcium, it's very difficult for you to be able to reconstruct. Many times you have to occlude the parent artery, and you need a prophylactic bypass. In very large aneurysms, or in cases with bad quality walls, we use prophylactic bypass from the beginning. The reconstruction with clips, sometimes in small aneurysms, because we can overcome the endovascular with the clip reconstruction. Here I have an example of a small but very complex MCI aneurysm, very easy to treat, but not that easy endovascularly, because several domes with a broad neck. And I'm sorry, but I can't run the video. Here I had an example of clip reconstruction with clips in a small aneurysm. Sometimes the aneurysms are huge, like this one, and we know we can reconstruct them, of course. In these cases, we use the prophylactic bypass many times, and the important thing is the first pilot clip to lower the size of the aneurysm and be able to end up reconstructing the aneurysm without temporary occlusion. The second issue with the complex aneurysms is the management of perforating arteries. We use cotton to separate, good exposure, and you need always a 3D vision. It's very important to try to be able to look 360 degrees around the aneurysms, because there are some locations like the carotid bifurcation, basilar tip, and other locations in which it's very important to deal with the perforators. I had here an example on how but again, I can't run the video, but it's a good example of using the cotton to take away the perforator from the field. This is a ICA bifurcation aneurysm. This is another example of bifurcation, ICA bifurcation aneurysm. In this case, it had a contralateral ophthalmic aneurysm, and we could clip this aneurysm, carotid bifurcation, ICA bifurcation, and besides be able to contralaterally through a mini-terminal approach treat the ophthalmic aneurysm. When you go contralaterally to the ophthalmic aneurysms, we don't use, of course, this in large aneurysms, but with the small aneurysms, you don't need to take out the anterior clinoid, because when you go from medial from the contralateral side, you have more room and you don't need to open the distal ring and take out the clinoid, like in this case. Management of the perforator arteries, very important. The choroidal artery. This is a reconstruction of an ICA aneurysm. You can see the anterior choroidal. This is the issue here. With this aneurysm, we decided to reconstruct it. And I have this example to show you how this is the anterior choroidal. We checked with ICG, with everything was okay. But we didn't have neurophysiologic control of this patient. And after the surgery, it suffered an anterior choroidal infarction. He partially recovered later, but not to the not 100%. So it's very important, very easy to control the anterior choroidal. All these cases should be neurophysiologically monitored during the surgery. Very important. When you have a problem with an anterior choroidal, it's very fast. You lose all the motor potentials very fast, and you release and you recover the thing. So please always use neurophysiological monitoring for these patients. In anterior about the clipping strategies, because there are some aneurysms, especially in ACOM and other locations, that are complex because of the location. And the problem with the anterior with the ACOM aneurysms is that sometimes we normally operate these cases through the pterional approach. We think is much faster and simpler than the interhemispheric approach. We reserve the interhemispheric approach for some large and very complex aneurysms, but I would say 90% of cases are treated in our center through the pterional approach. And the problem is that sometimes we don't have control of the contralateral side until very late in the surgery. So we have to keep a schedule, a pre-op schedule, and follow this schedule. And it's very important in these cases to use the clip strategies with fenestrated and with other. The pterional has another advantages. Many cases in our setting that they have several aneurysms, and we can track both several aneurysms in one setting using this. This was an example. In some cases, we take out a bit of gyrus rectus, the gyrus recti, because it's safer sometimes to do that, to take out, nothing happens. If you only take a small piece of gyrus rectus from one side, nothing happens. And sometimes it's better than to retract in some cases, in some complex cases. This was an example. Again, I can't run this video. This is the exposure we have. Here we have the, we're coming from the right side, proximal control. This is the left A1, the right A1. We have bilateral control, and then we use here a clip, a single clip. But sometimes we need reconstruction with clips. Look at this. If you listen to Pablo Rubino's talk this morning, he was talking about the orientation of the ACOM complex. They 50% of the times, the left side is anterior to the right, the left A2 is anterior to the right I2. So in the end, this kind of aneurysms, the dome of the aneurysms is projecting, looking at the right side. But in this case, we have also a MCA aneurysm, but from the left side. So we have to deal with the MCA and then with the ACOM. But in this case, the aneurysm is looking to the other side. Unfortunately, I can't run the video, but I tell you what happened. What happens in this case is that we don't see the aneurysm. So we have an anterior projecting, A2 in the left side and a posterior in the right side. So it's looking to the other side. What do we do in this case? What do we need to do in this case? To take out a bit of anterior of gyrus rectus in the left side, and then from behind we can check the other A2. And in this case, we use fenestrated clips. In this case, we use 3 fenestrated clips through the A2, and we have control of everything. Unfortunately, I can't show you. Probably tomorrow, if we solve the problem, I will show you some of these cases because they're interesting. Now we're dissecting the chiasmatic and the laminar terminal cistern to prepare the clip for the Ica aneurysm. And now we have the exposure here of the Ica aneurysm. I will show you. Let me. And now this is the final situation with the here we have the MCA clipped, and now we have 3 fenestrated clips. In this case, it's very easy. If we didn't have fenestrated clips, would have been impossible to deal with this without a lot of risk. Don't forget the use of fenestrated clips. In this giant aneurysm, Ica aneurysm, in this case, you see this is giant. We don't dare to use the pterional approach. In this case, we use the interhemispheric approach, because in these cases we prepare for a lateral A2 to ACA to ACA aneurysm. Here in A3 or A4 we perform this, but in this case, luckily for us, we were able to reconstruct. The aneurysm has a neck, and we take out the aneurysm, because in this case this aneurysm had a mass effect. In this case, kind of aneurysms, we always use the interhemispheric approach. Now we have, this was another example of use of a fenestrated clip. This is a SCA aneurysm. You see the basilar bifurcation. This is the one PCA, the other PCA, and here we have the superior cerebellar arteries. And we have this nasty but small aneurysm of the basilar SCA. And in this case, we could choose between a transcavernous approach to be able to mobilize the third nerve, or to use a more minimal invasive approach. But in this case, we can't mobilize the third nerve. In this case, we use a fenestrated clip avoiding the third nerve. You see how we did. Here we have the third nerve with a very small pretemporal with mini-pterional aneurysm approach, excuse me. And now we have here, this is the SCA, the basilar, here is the basilar tip, and this is the aneurysm. And we were able to treat the aneurysm with a fenestrating clip respecting the third nerve. The patient didn't suffer any third nerve palsy after the surgery. So again, it's a very atypical case, but fenestrated clips and new clips are very, very important to make the aneurysm surgery easier for us and safer. Then about the management of the perforating arteries of the M1 segment, if they're small, they need neck exposure and huge exposure. They are large, always in M1, they need a bypass. Why? Because in M1, we have perforators. This is a case, a 37-year-old male with subarachnoid hemorrhage. And he had this nasty aneurysm. Probably I would like to show you the video of the preparation of this aneurysm. And tomorrow we will try to show you this case. But to understand the case now, it's a rupture case with this M1, a huge aneurysm. You see the perforators around here, some coming off, not directly from the aneurysm, because the aneurysm has a dorsal projection. And these are more ventral, the perforation, the perforators. So, but these are in the same segment of the aneurysm. In this case, it's not possible to reconstruct the aneurysm without and avoiding the risk of regrowth of the aneurysm in the future. Probably these aneurysms are kind of dissections of the M1 segment, and we have to somehow to occlude just proximal to the aneurysm and be able to reconstruct the aneurysms, because we have had some problems in patients only with proximal occlusion of the aneurysm because of regrowth and sometimes even bleeding. So we have to do both things, proximal occlusion and reconstruction. The first thing we do, of course, is a bypass. In this case, it's a M1 aneurysm. We use both STAs to have two branches. We prepare one, the ATAs anterior to the upper M2 trunk, then the posterior STA to the inferior trunk of M2. And once we have prepared the bypass, we go to the aneurysm. We put a temporary clip in the ICA because at that point of the surgery, we can't see the proximal M1 segment of the artery because of the size of the aneurysm. So we have to put a clip on the proximal ICA. And then is the final situation. We put here a clip just proximal to the aneurysm, and then we reconstruct. I'm sorry, I can't show you the video now because it's not running, but we reconstruct the vessel with clips, allowing the flow to reach the perforators. Let me see if we can. Here we have all the perforators. We preserve them all. Let me see if this runs. It was the angio to check all the perforators. So we reconstruct. Here we have the reconstruction. This is the proximal clip, and this is the reconstruction of the vessel. You see, we see the vessel, small segment of the vessel, but still open, but with the proximal control. The blood is coming from the bypass. So this is the best treatment for this kind of aneurysms. In the ICA aneurysms, when we feel it's impossible to reconstruct them, when they have calcium and the calcium and the wall quality is, in these cases, is more important for this thing than the size of the aneurysm. In other words, you might have a very huge aneurysm, ICA aneurysms, but as long as you have good quality of the wall of the aneurysms, you are always able to, you can be able to reconstruct because we always control the carotid and we use the suction decompression technique from the cervical carotid, and you can reconstruct it. But if the aneurysms have calcium in the wall and the wall quality is bad, we never can reconstruct these aneurysms. So if we see the quality of the aneurysms, and you can check it in a CT before the surgery, is the most important single factor to decide if, when to bypass or not to bypass a ICA aneurysm. If there is no calcium, most of the time we're going to be able, in experienced surgeons can do that. Here we have this case of bilateral paraclinic aneurysms. You see there is no calcium in this right side one, and a bit of calcium in the left sides. So in this case, we don't need prophylactic bypass, and in this case, we would need prophylactic bypass in the left side, but not in the right side. And so first we operated on the right side. This is the right side, you see. It's huge, but can't be reconstructed. We think almost 100%. This is the final situation. This is control, the right side. And then later we went to the left side. It was more difficult because of the calcium. Look at the blades of the clip because of the calcium. The occlusion test. When we plan to the occlusion, when we're dealing with complex aneurysms, and a bypass is a possibility in the surgery, we perform a balloon occlusion test, a BTO. And when we check the BTO, we pay attention to the venous times. If there is a delay in the venous phase of we always feel that we need a bypass. Like in this case, this is a giant ICA aneurysm with occlusion test BTO not tolerated, and some collateral circulation from the ACOM, from the other hemisphere. So in this case, we felt that we needed a bypass, but probably not a high flow bypass. And this is what we did in this case. It's a difficult reconstruction without, and it might be possible, but very difficult. In this case, we don't see that much calcium in the wall, but because of this wide neck and the size of the aneurysm might be difficult. So in this case, we perform the bypass. In this case, we came from the first thing we did, cervical carotid exposure with the superior thyroidal artery exposed to perform the balloon occlusion test. This is the first step. Then we open, of course, the sylvian. We take out the clinoid. We do the cranial base thing. The next, we take out the anterior clinoid, open the distal ring, free the optic nerve in the optic canal completely. Then we open the sylvian fissure, expose the carotid and chiasmatic cisterns, and we join with the extradural dissection we perform. We end up opening completely the distal ring, and we can explore the aneurysm. Here we have, this is the situation we have. Here you see in this segment the optic canal open and the huge aneurysm. Here you see distally, and now we prepare ourselves. We enlarge the opening of the distal ring and the optical canal. Okay, and now we are opening. Now we are opening, releasing the clinoidal segment of the carotid in order to get more room for the clipping and to have the possibility of putting a temporary clip. But in this case, we prefer to do at first the suction decompression technique. And that's what we're doing. We try to put a temporary clip proximal to the aneurysm. And then we try we put a distal clip, temporary clip, to allow for the suction decompression technique from the neck. Now we clip. This patient has also an MCA aneurysm. We're treating the aneurysm right now here. This is what you see there. And now you see. Now we deal with the ICA aneurysm. We put a distal temporary clip, and now we suction from the neck, and you see the aneurysm is absolutely collapsed. And now we make the decision if we reconstruct or we definitely occlude the proximal neck of the aneurysm. You see the aneurysm is absolutely collapsed, you see, and we try to put a clip. And in the end, we can't occlude exclude the aneurysm without occluding the carotid. And we do that by putting a clip proximal to the PCOM. And so the aneurysm is treated. I can show you the videos. These are the videos of the angios afterwards. So in this case, we felt that was going to be necessary to do a bypass, and finally we did it. I'm going to finish the lecture with this. Sorry I couldn't show you the videos. We will try to fix this problem, and tomorrow we will be showing you cases. Thank you very much.
Thank you, Dr. Llanos. Are you going to introduce Jorge?
Yeah.
Dr. Llanos?
Here we now the next speaker is our good friend, Dr. Mura. Doctor Mura. Ay, ya no comparto yo, ¿no? Ya no comparto yo, ¿no?
Sí, porque la estamos viendo.
A ver, dejo de compartir, ¿no? A ver.
Sí. El rojito.
Yo creo que Jorge empecé a...
Ok. Now, Jorge Mura it's about to give us a talk about the. Jorge Mura is, you all know Jorge Mura. He's very famous now, and he has one of the most important experiences in the world in paraclinoid aneurysms. And in the last years, he's been involved in improving the transcavernous approach to the clivus and to the posterior circulation using what we call the hemiplata approach. I think he's going to talk about the hemiplata approach. We are sorry he couldn't make it personally to our course this year because of the situation we have in the world, but we hope next year he will join us together. Thank you very much, Jorge, for your attention today. I know you are on vacation, but you always are available for the friends. We know you. Thank you very much.
Thank you, Kiko, for your introduction. Can you hear me okay?
Yeah, yes,
Yeah.
perfect.
Can you see my screen?
Yes.
Okay. Then today I'm going to talk to you about the hemiplata. Hemiplata is good for the people who speak Spanish because it's my money in Spanish, and but in the real thing is an acronym of the variation of the pretemporal approach. The pretemporal approach were described in 1995 for my professor, Dr. Evandro de Oliveira, and we designed first the mini-pterional, extradural mini-pterional approach that we use in the paraclinoid aneurysm since 2015, sorry. And I will talk about that tomorrow, the same hour. And the next step of the surgery using the extradural mini-pterional was the development of the mini pretemporal approach that we developed first for the sphenopetrocleidomastoid meningioma. And I will show you the philosophy. The hemiplata is a philosophy. Why? Because it's the philosophy of the patient with a tumor in the cavernous sinus applied to a patient with a tumor in the posterior fossa, and using the cavernous sinus only as the route to reach the posterior fossa. This concept is not mine. The first who talked about the highway of the cavernous sinus, the posterior fossa, was Ari Krishna. But the difference with me is I tried to use minimal invasive concept in order to reach the posterior fossa. I think strongly that you don't need a huge approach in the outside when your problem is in the bottom, is in the skull base. You need a huge approach in the outside when your lesion is in the surface. Okay. The first concept about this is the keyhole concept. The keyhole concept is a small opening outside because you're going to use, for example, endoscopy in order to put your operative field in the bottom of the surgery. But in the skull base, we cannot do that, especially in vascular surgery. Why? Because one of the most frightening enemies of the endoscopy is the bleeding. And I saw this in the transsphenoidal route when they have, for example, a lesion in the internal carotid artery. They cannot see nothing, only packing. But we in microsurgery, we can deal with this. We must deal with this, especially in rupture aneurysms. And then I try to came with a new concept that I try to make a profound analysis tomorrow about the key exposure concept. The key exposure concept is different. It's opening the less in the outside and the most in the bottom of the surgery. And that's the main teaching of the hemiplata concept. And finally, after a long way that we must pass through, we can finally publish this in this year, a couple of months ago, at the end of August, the hemiplata, and the hemiplata now is in PubMed. And for the sphenopetrocleidomastoid meningioma, this is a paper published for my fellow from Spain, Rafa Martinez. Now he works in the United States, and his picture of the fellow. And the thing is to use the cavernous sinus as the way, in this case, to, for example, to resect the most of the tumor that you can, but in the vascular pathology, the Miplata philosophy is about to use the extradural route to reach the posterior fossa. The most important difference with the classic concept that use Dr. Evandro or Ali Krish or Vinko Dolens, they use the roof of the cavernous sinus. The transcavernous approach of them is the focus of the transcavernous approach is the roof, is the Dolens triangle or the Hakuba triangle or oculomotor triangle. And they only release a little bit the tentorium in order to can mobilize the third and the fourth nerve. But in the Miplata concept, the surgery, you use everything. You use all the lateral wall of the cavernous sinus because you release the third nerve, the fourth nerve, and the fifth nerve. And then you are not using the superior or the roof of the cavernous sinus anymore. You use the posterolateral way. That's why the Miplata had this name. But in together with this, you use a minimally basic concept. You don't need to take out the orbit. You don't need to take out the zygoma. You don't need to make a huge bone flap in the outside because the pathology is in the cister. Okay, in vascular surgery, it's in the cister. And in tumors, we use the tumor as the retractor. For me, for example, when I operate a sphenopetrocleidomastoid meningioma, I prefer most a big one because a big one separates for me all the structures. When I operate a small one, it's more difficult for two reasons. Because the cavernous sinus is alive. When I said the cavernous sinus is alive, you had venous bleeding, and the space that you have is minor, okay, because the tumor is not working as a retractor. It's very important the concept of the tamponade of the cavernous sinus in a fashion that you can repeat and reproduce. We use the fibrin glue. Fibrin glue is nothing new. It's published in 2007 for Yuha, Ali Krish, Laligam Shekar, a lot of people. But really for cavernous sinus surgery, the fibrin glue is magic. Because when I was in my fellow in 1998, Dr. Evandro used Surgicel. And the problem with the Surgicel is the Surgicel produces a mass effect, okay? Because you need to make a compression to stop the bleeding. The fibrin glue replaces the venous content of the cavernous sinus. And the good thing of the cavernous sinus is a lot of compartments. You know, the cavernous sinus is divided in a lot of spaces. And then when you put the fibrin glue, you're not coagulating all the cavernous sinus. And this is published as well, because the people who don't like the extradural route, for example, to take out the clinoid, they said that you can have a thrombosis of the cavernous sinus, you can have a ophthalmic or retinal infarction because some median meningeal artery can irrigate the retina. And I studied this about these 2 points, and nothing happened if you use fibrin glue in the cavernous sinus. It's almost nothing published about a problem. There's a recent paper who talk about in 3,000 or maybe patients a thrombosis of the internal carotid artery. But for me, if you analyze that, maybe it's not for the fibrin glue, it's the volume of the fibrin glue. That's why you must use the small one, 1 milliliter. Never use the 3 milliliter, because it's important that you use the less volume possible for this kind of surgery. Okay, and then the people who said that the ophthalmic artery came for the median meningeal, that's true. But the publications in anatomy said that most of the patients who have a median meningeal artery giving intraorbital artery, that artery most of the time, I've never seen the central retinal artery is always coming from the carotid artery. It's not coming for the median meningeal artery. What coming for the median meningeal artery is the irrigation of the content of the organ. Okay, and in I don't know, maybe 800 anterior cranioidectomy or middle fossa approach that we did cutting the median meningeal artery, we don't have a retinal infarction in no patient. We have optic compromise, but the optic compromise is for the pathology, the compression, for example, for an aneurysms or whatever. But what you have with the infarction of the retina is a wide retina. Okay, it's not a problem of the optic nerve; it's a problem of the retina. And then you can, with a neuro-ophthalmologist, you can see the problem. In this paper that we finally published, we made a video, okay, in order to show what's the philosophy we will talk today. And this I want to share with you that I never do all the surgery, okay? My fellows can do the mini pretemporal, they can do the middle fossa peeling, or in other words, separate the dura propria of the temporal lobe with the carotid oculomotor membrane of the cavernous sinus. This is a dissection made for Tomás Poblete, one of my fellows, to showing the principle of the mini pretemporal approach. The mini pretemporal approach is an extension of the mini pterional. The only definition, anatomical definition, is you never pass the superior temporal line. But I always say that never or always or nothing or all is not good to say in medicine. And then when the patient have no frontal sinus, you can extend a little bit up. Okay, the concept of the mini pretemporal, mini pterional approach in the patient is more comfort for the patient. Okay, another thing very important is the takeout of the anterior clinoid. We never in a tumoral patients, we have no rupture or lesion of the carotid artery. In no case. The two cases that we have lesion of the aneurysm were special aneurysm that I didn't, in very old cases, 15 or 17 years ago, that I didn't see properly the CT angio of the patient, because the two cases have a transitional aneurysm. What is that? It's an aneurysm in the ophthalmic segment, but have a portion of the aneurysm in the clinoid segment. And then you must to be careful if you have in the clinoid segment some part of the aneurysm, because you need to avoid to lesion the sac. That's the problem in the two cases that have rupture. After that, now when I have a clinoid portion of the aneurysm that is in the clinoid segment, I take more care and take out the clinoid. But even if that exists, I always do extradural. Almost never I use the subdural route, because for me it's safer. Two cases in 800, and the two cases, the good thing, because it's extradural, the bleeding in that patients were extradural. And then what we did, we put a clamp in the cervical portion. I opened the dura. I put a clip in the carotid artery. After that, after the trapping, I suture the aneurysm in the two cases, and after that I clip it. The two patients did well. The first patient have a facial palsy, because you must remember when you do a peeling, because in that patient I exposed the petrous segment of the carotid artery, because I thought that I was not able to clip, but at the end of the surgery I can clip the aneurysm, and I pull the GSPN. That's why the patient have a facial palsy. Okay, and then it's very important to say that if I see the complication of rupture for extradural craniodectomy is 0, because the morbidity is only facial palsy. Okay, and then it's very important this, because I heard in every panel that everybody talk about the danger of the extradural craniodectomy. There's no danger. In our experience, most of the cases, I don't take the clinoid. My fellows take the clinoid. My residents take the clinoid. And no problem. When we have a tumor, I left the residents or the fellow take out the clinoid, because in tumors, 0 rupture, 0, never. In aneurysms, clinoid aneurysm, I take out the clinoid. When we have a regular one, a carotid ophthalmic, for example, or a superior hypophyseal artery aneurysm, anybody can check out, because the rupture is only when you have clinoid. I'm sorry to stress too much this point, but I hear things that statement are done for people who doesn't use the extradural route. That's funny for me, because I can do as intradural drilling of the clinoid or sonopet of the clinoid, and I can do extradural, and it's not danger the extradural. If I don't do something, of course it's danger for me. If I operate a spine lumbar disc herniation, for me it's dangerous, because I don't do this in 20 years. Okay, and then you need to talk about what you do, not what the other people do. And in the case that they're showing here, show one of the most important concepts of the Mi-Plata concept, or the cavernous sinus surgery concept, is the releasing of the nerves. And the difference with all other publication and experience, that we do the opening from the cavernous sinus to the cisternal portion. Look at this third nerve, the compression, terrible, that have in the oculomotor triangle that we can release. Look at this, even have a bleeding. This patient is a pilot of airplane, and he started with the third nerve, and after the surgery, he improved the third nerve. And that's very, very important thing, because when I did this kind of surgery 10 years ago, and I didn't use the Mi-Plata philosophy, the recovery of the nerve was seldom. But the difference now is the instrumentation. What instrumentation? The Kamiyama scissor. The Kamiyama scissor, the shape, semilunar shape of the scissor, is the key in order to open the sleeve of the nerve and release the nerve from the cavernous sinus to the cisternal portion. Why? Because all the other scissors are straight, and you hit the nerve with the tip. In the Kamiyama scissor, you never hit the nerve because you follow the nerve. It's something that the people can say that it's not so important, but it's the key. It's the most important thing. If you don't use a semilunar scissor, you cannot do this. Look at the shape of the scissor. And then in this case, the third nerve is released. Now I'm releasing the fourth nerve. It's very important to know that the fourth nerve in the cisternal portion, because of the compression in this kind of patient, is sometimes 2 or 3 times more thick than the cavernous portion. It's very important to know that the fourth nerve in the cavernous sinus is tiny. Here we're taking out the tentorium. And why you take out the tentorium? In order to release the fifth nerve. Most of these patients have a trigeminal neuralgia. And then it's very important to know that you need to release the fifth nerve. Why I put the Doppler here? Because the posterior vein of the carotid artery and the sixth nerve coming through here. This is an old case because I leave a lot of tumor into the cavernous sinus. Now I'm trying to go inside the cavernous sinus in the patient because I have more experience. Here we are releasing the Gasserian ganglion, because it's very important to release all the trigeminal nerve in order to patient have not the trigeminal neuralgia. And this is all the philosophy. Why I show this video at the beginning of the lecture? Because I know that most of you don't understand nothing, okay? Because it's complicated, okay? And then we will follow to show you that this is published, and this is my conflict of interest. And the first thing I always do is to be grateful with one of my mentors, the Professor Evandro de Oliveira, and I spent with him 1 year, and I learned the 2 things that are more important. And it's funny for me because this picture I put in my lectures for more than 20 years. And I never realized what the picture showed to me. This is a dissection of Elder Tedeschi. He's a very good neurosurgeon from Campinas, Brazil. He taught me a lot when I was with Dr. Evandro. He was the fellow Dr. Evandro, Dr. Roton as well. He went Hung-Tu, who were, according to Dr. Roton, his best fellow in neuroanatomy. And the elder gave me this dissection of him. And you can see here the Mi-Plata philosophy. Why? Because if you see the roof of the cavernous sinus, you have the anterior and the posterior clinoid, okay? In order to reach the posterior fossa. But if you came for the posterolateral side and you take out the tentorium, you have no bone in between the anterior petrous bone to the posterior clinoid. And then you have this huge space that is limited in the bottom for the entry of the sixth nerve to the Dorello canal. And then it's very interesting. And I saw this for more than 20 years. I never realized that this was a way to operate the patients. And then in 1998, I knew this Argentinian neurosurgeon, Eduardo Seoane, and I started a very high obsession with the clinoid segment of the carotid artery in that time. And I learned a lot about that. Now everybody talk about the carotid cave aneurysms, because now you have everything. You have written in YouTube, you have hundreds of publications, but in that time was very difficult to understand all this that happened with the carotid. But what I said to my fellows, remove the anterior clinoid process and release the carotid. The third nerve at the optic nerve is the entry of the skull-base surgery. Is the maneuver that we use most. Of course, if you operate a posterior fossa lesion, no. But even in posterior fossa, you use the same concept. For example, when you release the vertebral artery, what are you doing? You are releasing the vertebral artery for the occipital cavernous sinus. It's the same concept. And what is your clinoid? Your clinoid is the condyle of the occipital bone. You see, you apply the same philosophy even when you release the vertebra. For me, when I said the far lateral approach for me is the Hakuba approach of the vertebral artery. It's the same philosophy. Okay, the anatomy never lies. And the other thing, I was very lucky because I knew in that time, because I made a fellow with one resident from Dr. Akira Hakuba. Akira Hakuba described everything in 1982. He described the lateral wall of the cavernous sinus, the Parkinson's triangle opening, the extradural anterior craniodectomy, even the transpetrosal approach before Kawase. Kawase described the approach, I think, in 1985 or something. In this paper is everything in the paper. The problem is the paper was published in Japanese, and then nobody knows about what said the paper. And what we did in 2019 was translate this paper. We translate it, and everything is in the paper. If any one of you want the paper, I can send you for email. And I study a lot the anterior craniodectomy. The anterior craniodectomy show the philosophy of the neurosurgical different schools. Why? For example, the North American people use a lot now they are getting the extradural, but most of the time they use the intradural craniodectomy. Why? Because it was introduced for Charles Drake in 1968. And if you see the people from Europe, they use a lot of the combine. Why the combine? Because Vinco Dolens used the combine. Is using a partial extradural opening of the lateral wall of the cavernous sinus, named mini peeling for a lot of people, in order to expose the bottom of the clinoid. But he opened the Sylvian fissure because he need to drill the clinoid, because Vinco Dolens is not, now, of course, but I'm telling the beginning. In the beginning, he didn't open the meningoorbital band completely, only a small portion. And then you need to open the Sylvian fissure, take out the CSF in order to drill this. The difference with the Hakuba school from Japan, he did a complete peeling of the middle fossa, and then you can take out all the clinoid just without any opening of the dura. That the concept that we use. I thought when I started in 1999 that I did the Dolens approach, but really what I did was the Hakuba approach. Why? Because I use no drill technique. Why I use no drill technique? Because in the beginning, because I have no high-speed drill in my hospital, but the drill came shortly after I arrived from Brazil. And the other concept that is the real concept is the heating. The heating for me is the cause of the lesion of the optic nerve. Okay, the peripheral nerve can take some heating, the third, the fourth, the sixth. Not direct heating, heating with the bipolar, but some heating. But the optic nerve, you must remember that it's a tract, like the spinal cord, and then the optic nerve not tolerate nothing, and then any heating of the optic nerve can give you a problem in the nerve. And I will show you some publications that show that now. Now, of course, in order to develop a good surgery, you need to know the right people. Yeah. Now that Kiko said that I'm famous, when I knew Kiko in 2013, I was nobody. Okay, I knew Rokuya Tanekawa in 2007 because we shared the philosophy of cisterna cleansing in subarachnoid hemorrhage that he published in 2007. But I knew Kiko in 2013. That's why I put the that year important for me because Kiko opened the world for me. I always be grateful because before Kiko I was nobody. After Kiko, I am somebody. And the other thing in 2015, when we went with Kiko to Japan, to the Shinkai, to the hospital of Rokuya, and we can saw there the secrets of the Japanese people. Professor Kamiyama is in the left of the picture, me with a lot of more weight. Now I lost 20 kilos. Kiko and Rokuya. And we saw all the instrumentation that they have. The main thing that I learned was the scissor. The scissor is the key. And the other concept is the suction irrigation. Okay? And then when we remember the anatomy, we must know a lot of anatomy in the cavernous sinus to operate cavernous sinus. And it's important to know the names because the names show you the history of the thing. The clinoidal portion of the roof or Dolen's triangle, the oculomotor triangle, the Jacobo triangle when you release the third nerve, the supratrochlear that most of the time is hard to opening because the third nerve with the fourth nerve most of the time came together. And in surgery of the cavernous sinus, it's much better to keep them together. Why? Because you can preserve the irrigation of the nerves when you open in the cavernous sinus. For example, a transcavernous approach for adenoma, pituitary adenoma. You must leave together the third and the fourth nerve. It's much safer. And you can open in the infratrochlear triangle, the Parkinson triangle. Why? Because you can find the posterior vein of the carotid artery and coagulate the meningopophyseal trunk in order to control the bleeding. And the other thing, very important, when you follow this, is find the sixth nerve into the cavernous sinus. When I made this question to the fellows, they never answered. But you must remember the anatomy of the first year in medical school. The only nerve inside the cavernous sinus is the sixth nerve. All the other nerves are in the wall or in the roof. You need to remember that. And when I show them a nerve inside the cavernous sinus, can only be the sixth nerve, nothing else. Nothing else inside the cavernous sinus. And this picture that is already showed by the Kiko in his lecture is the paraclino. The paraclino teach me a lot about the cavernous sinus. Why? Because I need to be a master in opening the roof of the cavernous sinus in order to treat, for example, the carotid cave aneurysms, the superior hypophyseal, or the lateral cave aneurysms. That is a new classification because we have some of these cases that came infraclinoidal. The superior type of paraclino named carotid ophthalmic for Drake, you don't need to open everything. Even you can clip without take out the clinoid. You can clip just opening the roof of the optic nerve. But the advantage to take out the cavernous sinus is you release the carotid. You release the third, and you can put the clips in the direction of the carotid artery. When you just take out the roof of the optic canal, the maneuvers that you can do with that technique are less. That's why I prefer to take out all the clinoid. We have more than 400 cases for paraclinoid now. I think maybe 450 now because we still operating in the pandemic of the COVID. And then we change. We use the classic thing from 1999 to 2014. I show always this slide. This slide were done for my friend John Olave, and we changed in 2015. That's why I said this to you, because you can change in every point of your life. When you are getting older, it's hard to change. But if you think that the microsurgery is a good thing to keep going, you need to change, because we cannot do these huge openings forever because they are not needed, and we have to have a competition for the endovascular techniques. And then we need to offer that to the patient the same safe surgery, long-term surgery, but with less invasion, to better recovery, better results, optic nerve, cranial nerves, etc. And these are the secrets that I learned in Japan. The suction irrigation, first I use this. This is the Suction Plus developed for Professor Kamiyama. This is the scissor, of course, the 2030-18, because I use a long version of the scissor. This is the key, good for everything. And now we have the supersuction developed for Rokuya that have some better qualities than the old one, but you can use, I use both up to date. And then I start first with the supraorbital because we follow a lot of us follow Yuha, Ernest Niemi. And that's why we start using the supraorbital, because when I want to do a less invasive approach. But the problem with the supraorbital for skull base, why I rather prefer the mini-pterional, is in the supraorbital you open the frontal sinus, because the superior temporal line is the limit to the lateral extension of 99% of the patients of the frontal sinus. That's why we prefer to use the mini-pterional, because the upper limit of the mini-pterional is superior temporal line, and then you never open the frontal sinus. In skull base is very important because the CSF leak is one of the main complications. And then when you open the cavernous sinus and you open, for example, the optic canal, the most of the patients, the fistula that you have will go for the sphenoidal sinus. In the sphenoidal sinus, it's very easy to repair from the transnasal route. And then we don't have fistula, but when we have a suspicion of any fistula, I asked to my endoscopy guy who made the reparation of the fistula through the nose. I don't need to open the head again. Of course, we have exceptions. For example, the Onodi cell of the optic canal that opened the ethmoidal part, drain directed to the ethmoid. But in the problem with the frontal sinus, you need to open the head to repair the thing. You can repair for endoscopy, yes, you can repair, but it's very hard to came from below. And then the most important advantage for me of the mini-pterional approach, for example, when you use a fenestration of the lamina terminalis for hydrocephalus, is you don't open the frontal sinus, and then you have no risk of CSF leak. And we start to think a lot about what approach to use with Rafa, with one of my young colleagues in the hospital, Alejandro Coop, and we came with the thing that we showed to you. But I always want to say that this is nothing new. The first mini-pterional-like surgery was published in 2005 for Edgar Natal. That the technique is a one flap with the muscle in order to expose the bone. The good thing about this surgery is mainly for example, for middle cerebral artery aneurysms or PCOM or whatever. But if you want to go to the skull base of the Paraclinic, it's a little bit hard because of the muscle. And then in 2007, came the concept of Everval Gadelia from BNI with Dr. Spetzel, the mini-pterional. The mini-pterional is defined for the extension. It's anatomical craniotomy. It's not a keyhole craniotomy. It's anatomical craniotomy that you can do keyhole, or you can do whatever you need for your patients. Very versatile. Why? Because you can do a keyhole mini-pterional. The limit is superior temporal line, for example, for an MCA, or you can do a no keyhole mini-pterional, because you can extend to the back of the surgery, to the skull base. For example, the mini pretemporal that we use for the sphenopetrocleiva. Okay, the anatomical limit here is the most important concept to avoid the opening of the frontal sinus. And why it is different? Because we use the interfacial dissection of the facial nerve in the muscle. That I learned with Dr. Evandro. Everval learned with Dr. Evandro because he made his residency in neurosurgery with Dr. Evandro in Sao Paulo, and after that he went to Spetzel. And this maneuver is very good. Why? Because in a skull base you can expose more to the skull base, and the other important thing is that you can obtain a graft for the reconstruction after the surgery. The superficial, the temporal fascia, it's very good to repair the defect that you leave in the APC meningiomas, and you can obtain fat, because you must remember that the flap that you use for the facial nerve and anterior portion, but you leave fat in the surface of the temporal muscle. You can take out the fat and use that for reparation. It's very good. This picture I take with Dr. Natal at my left, Dr. Everval on my right in Cancun 2016. And this the keyhole concept is just the size of the craniotomy. But this is the mini pterional is more than that, because it's an anatomical based concept that can be keyhole or cannot be keyhole. We don't care about that. We use depending of the patient. You tailor the approach for your patient in particular. And a lot of criticism came, of course, because of the pterional is better or whatever, but the study was done, and then the view that you obtain with the mini pterional is the same. We are talking about lesions, vascular lesions in the bottom of the surgery, in the profound or skull-based lesions. Of course, if you have a lesion in the surface of the brain, for example, an IBM, glioma, meningioma, whatever, you need to do the craniotomy in the size properly for the pathology. And then we don't talk about that. In that, you use pterional or whatever you need for the patient. We're talking about cisternal lesions here, or posterior fossa lesions. And then the key exposure concept, or the deep exposure oriented approach. Okay, and here we talk about this and the key exposure. You know, the classic is Jasserhill, or in the left there you can see the Dandy approach. The Jasserhill approach is a small Dandy version. I imagine when Jasserhill came with the approach in 1975, or no, I don't remember properly the year, 75 or 77, I don't remember. The criticism will be huge. How this man for Turkey is going to change the Dandy approach, because it was less invasive. And the same concept came with Pernesky in 1998 when he described the supraorbital, the keyhole, of course. And now the same thing. We don't need a pterional in order to do a good bottom surgery in the skull base, because we use the extradural corridor. What is the extradural corridor? Here is the dissection of Thomas, mini pterional, meningorbital band, section of the meningorbital band, lateral wall of the cavernous sinus, take out the clinoid, optic canal, clinoid segment of the carotid artery, B1, maybe fourth there. You can see everything. You don't need to expose the frontal lobe for that. You see, you just need to expose the portion of the skull base that you need. And then came with the mini Hakuba, mini Kawasser, mini Dolenk approach. Okay, and we finally can publish this, the micropterional keyhole, real keyhole for optic nerve decompression that we use, for example, for fibrodysplasia of the bone, or tuberculum cella meningiomas, because in the tuberculum cella we are not operating anymore for the interhemispheric approach. What we do is release the optic nerve, the carotid artery, using a keyhole, sometimes bilateral, and after my colleague take out the tumor from the nose. I think I don't operate for 3 or 4 years on a tuberculum cella, and I operate more than 40. And then when they came with this surgery or about decompression, we see, oh, okay, we can see everything here. We can see the carotid, the optic, the lateral wall of the cavernous sinus. Why we don't operate some cases? And tomorrow I will show you that you can operate ophthalmic aneurysms, select cases using this approach. And then, of course, it's published because we try to publish everything now in order to have a good discussion, academical discussion. And finally, in 2019, we can publish the mini Hakuba approach. The mini Hakuba approach is the extradural mini pterional approach. This is the first step to came with finally with the Mi Plata. We show this in the advantage in the paraclinoid region, the mini Hakuba for paraclinoid that show tomorrow, and the mini pretemporal approach for the sphenopetrocleidomastoid. That is the first step to came with Mi Plata. And the most important thing is the teaching of the fellows. Why? Because you need to teach. Because if you operate very nice, you are very good surgeon, but you cannot reproduce this, you are lost, because nobody can do this. And one thing about the mini pterional, the extradural mini pterional, the extradural mini pretemporal, my fellows with 1 year they can do this surgery when they finish the fellow. And then when the people say to me, no, this is for very long curve of learning. Of course, it's a long curve. Was a long curve of learning for me, but not for the people that I teach, because I take the curve for them and I push them and I leave them better than me. They will be better than me. That's the idea. And this paper that we published in May of 2020 with the Kiko, with the Evervar Gadelia, you can see that we put a multicentric publication that is important about this philosophy. Even though Dr. Mura can do this, it means nothing. We need to reproduce. And I put here, in 1975 was the classic pterional of Jasakil. In 1987 was the interfacial Kakuba. In 1982, the extradural pure craniolectomy. Dolens in 1983, the combined one. Miniterional, like the original Jasakil description in 2005 for Natal, the interfacial in 2007. And after that, we came with this concept about the mini Hakuba, the micro Hakuba, and mini pretemporal approach. Remember, the instrumentation is the key. You need to develop instruments. You need to develop special rangers. You need to develop a special Kerrison in order not to use the drill. And I show you some examples to finish. The trigeminal schwannoma. In the trigeminal schwannoma, for example, in this case, you have most of the tumors in the posterior fossa. You can get for retrosigmoid, but the problem with retrosigmoid is to preserve the trigeminal nerve is hard because the trigeminal is in the front of the lesion. And this patient have a small portion in the middle fossa. It's non-dominant side, and then you see no natural draining of the anterior petrous. As I said, if you have a huge trigeminal schwannoma, the trigeminal schwannoma made the anterior petrosectomy for you. In this case, the trigeminal schwannoma doesn't help. And then what we do, this is a mini pterional approach. The orbit is here, the muscle is here, everything, because you use lumbar drain or opening of the dura and cisternal opening, and you have good view in the patient. You can see you made the peeling of the middle fossa. You push 2 stitches in the dura mater using your lumbar drain, and you got exposure of the tumor. And then what we do, we use the tumor as the way to reach the posterior fossa. But the good thing about this surgery, you can preserve the trigeminal nerve, okay? Because you're working in the side of the trigeminal nerve. And then what we do here is, this is the trigeminal root, B1, B2, B3, anterior petrous bone, anterior. And what we do a small drilling of the most medial portion of the Kawase triangle, because we don't need to expose the cochlea. We don't need to expose in the lateral side in order to put morbidity to the patient, opening the eustachian tube, for example. You don't need that, or lesion de carotid. You just drilling the medial portion, because what we do is using the mobilization of the trigeminal nerve. Okay, you mobilize the trigeminal nerve. If you mobilize the trigeminal nerve, you can go to the posterior fossa. You see, and what we do is dissection. Here you can put, if you want, an endoscope. We don't use it, but we want to use in some cases like this one. And you start to take out the tumor in the posterior fossa. And this is the posterior fossa tumor, the 5th nerve. And you can take all the tumor. This is the posterior bend of the carotid artery. This is the root of the trigeminal nerve, B1, B2, B3, and everything. You see, a tumor. This is the first concept. If you start to try to use miplata, please start with tumors to understand the philosophy first. And we take completely the tumor. We're going to skip this. We don't have time. Completely take out the tumor, because of course we need the MRI, but I saw that I take out the tumor. We drill completely the petrous apex. You can see here the internal auditory meatus. This is our bottom limit in this kind of surgery. And finally, the sphenic metaclavian meningioma, terrible tumors. Now I have more than 100. Okay, and the petroclavian meningiomas that I have my experience near to 150. And I start to apply the surgery for these cases that I don't have an answer. My head was exploded because I cannot treat this patient. I use what I learned classic, the posterior petrosectomy of Almefti, take out the posterior fossa tumor. After that came for the middle fossa and take out the cavernous portion. But I start to think why I better do the middle fossa, and after that came for the posterior fossa in order to preserve the nerves, because I learned this. And this is, we're going to skip, but this is when was a huge tumor. But I follow the same philosophy. releasing one nerve at the time. First the third, next the fourth. After that, I don't know what happened. Let me see. My computer is asking me for time. And then I release the third nerve, the fourth nerve. After that, I came for the fifth nerve. I will see if I need to drill the petrous apex, because most of the time the tumor made to you the surgery. And my limit in these cases are the facial cochlear vestibular complex, because I can came from the behind, from a retrosigmoid classic approach, and take out a remnant if I leave. I prefer to take out all this tumor, release the third, the fourth, the fifth, and after that came for a simple retrosigmoid approach in order to remove the tumor. Now this is thinking. And then we published this now. It was finally published in 2021 about the Mi Plata concept, and two-stage resection in our series. The results in cranial nerve are better than any other publication before, because I think that you release the nerves of the sleeves of the tumor, you know, and you relieve the third, the fourth, the fifth completely. If you came from just from the posterior petrous approach or the retrosigmoid approach, you are not going to relieve, for example, the third nerve to the Hakuba triangle, and that's a problem. Okay, and then if you use this surgery, you can release the nerve completely, the third, the optic, the fourth, and the fifth. Okay, and then the prognosis of the nerve is much better. When you came in the second stage from the retrosigmoid approach, your only concern in the surgery is the facial nerve and the cochlear nerve. You see, because the rest of the nerves are already released, and then results are much better. If you came from behind, you need to deal with all the nerves. If you came first for the middle fossa and use the tumor as the retractor, you only need to deal with the facial nerve and the rest of the nerve. Okay? I don't know what happened with this. It's the first time that I have this problem. Let me.
Yeah, you need a lot of bandwidth for that.
Yes. Okay, I'm going to open again and go to save time. And you already see the APC, and then I will show you what is Mi Plata concept. Mi Plata concept is applied the sphenoprotoclavial concept to the, let me move this. Okay, with this I'm going to finish. I need to move this, okay? And what is the Mi Plata concept? To apply this philosophy, but when you don't have a tumor. The neuroanatomy never lies. The only thing you need to take out is the tentorium. You need to deal with the bleeding of the cavernous sinus, but the bleeding of cavernous sinus you take out with the fibrin glue. Nothing new, published 20 years ago. Okay, now the fibrin glue, of course, can change the drain of the cavernous sinus. No problem with that. The problem is the patient have some bleeding of the temporal lobe. The bleeding of the temporal lobe that I saw in my patients, I have two venous bleedings, is when you have a small tumor that you don't realize of the drain of the patient. Now what we do, because this is published this year, I review a very nice paper about that. 60% of the patients are in danger because the patient have not good connection with the trolar or the Lavey vein. And then you need to do an angiography or a venous CT tomography to see if you have a proper trolar vein or a proper Lavey vein, you have no problem. Okay, maybe in 20% of the cases you have a contraindication of the surgery because all the drain is doing for the cavernous sinus. And then in that cases, you need, for example, if you have non-dominant side, you can check out a portion of the temporal lobe in order to treat your pathology, but you cannot cut the superficial Sylvian vein. And this is the most important problem that you can deal with in this. This is the Parkinson triangle. In the Parkinson triangle, you need to use a combination between a small piece of Surgicel combined with fibrin glue. The same thing for the superior petrosal sinus. No fibrin glue alone. No, because you had embolism even to the lung, and then it's important to avoid to use fibrin glue alone in that point. In the rest of the cavernous sinus, you can use fibrin glue alone. This is a very interesting paper of Ali Krish that he used this concept about the exposure of the lateral wall of the cavernous sinus for the PCOM, and we comment this paper, and we share that we use the same philosophy of Ali Krish, but using a minimally invasive approach. Classical pretemporal, I said to you before, the roof. We use the lateral wall. This is a dissection for my dear friend Pablo Rubino, and he showed this is the view. The view is the good view that you can get this in a patient if you deal with the cavernous sinus. But the good thing that we take out the posterior wall of the dura mater to the posterior fossa. This is nothing new. The decompression of the nerves is an idea of William Caldwell with Utah. He published in 2006, again in 2019. But the difference as we put this all together in a minimally invasive fashion that I already showed you. This is a dissection of Rafa. This is the classical thing, the peeling, the exposure of the nerve. But the thing that we do with our approach is taking out all the dura in the back of the cavernous sinus, and there you can expose even to the pica or the middle fossa in some cases. And you can see here, if you open the Sylvian fissure, you combine all the concepts, you can expose everything. And this is the classical cavernous sinus and roofing, but this is not just an unroof. This is complete takeout of the cavernous sinus with preservation of the artery and the nerves. And I will show you one case only of vascular pathology. This is a chondrosarcoma, chordoma, recurrent. And I show you the final view. This is a mini-pterional opening. And what we see here, we see the vertebral artery on the left side, the vertebral artery on the right side, the anterior spinal artery to the irrigation of the spinal cord and the medulla. This is the sixth nerve of the left side, the sixth nerve of the right side, left side, the trigeminal nerve, fourth nerve. And then the pathology give you the space. This is the petrous carotid artery here. And then the people say, no, the limitation of this approach is this or that. No, depends on the pathology. That's why you need to use your imagination for the surgery. Not have a plan before the surgery. The plan before the surgery for me is take out all the tumor. The plan before the surgery for me is clip the aneurysm or make the bypass. But in the surgery, I use all the tools that I have in order to get the proper exposure. And we take all the tumor in this case. You see the posterior fossa using a mini-pterional. And then I'm going to skip this one because I'm not interested in this case. We use the miplata to expose everything. You can see the fourth, the fifth, the third, and the carotid. We take all the tumor, okay? And this is the MRI of the patient, but this is important. This is the last case. With this, I'm finished. This is a high-grade subarachnoid hemorrhage for dissecting superior cerebral artery aneurysm. And this is the miplata concept. A bleeding, hydrocephalus, an infarction, fortunately, of the superior cerebral artery territory. But the problem, you have a complete dissection. I'm going to put pause in this one. Complete dissection of the superior cerebral artery. And I show you. Look at the aneurysm. Came from the basilar to the lateral wall of the, maybe in the lateral mesencephalic sulcus in the mesencephalon. It's terrible for any surgery because it's behind the posterior clinoid and just reach the petrous apex. And then what surgery we are going to do with this one? What are we going to do with this one? Fortunately, no bypass is needed because we already have the infarction. But what we do miplata. Because the miplata can expose everything. We take out the clinoid. Why do you take out the clinoid, anterior clinoid? because I need to release the third nerve, which is in the roof of the cavernous sinus, to mobilize this. Then we have the same. Let me. No, cerrar el programa. Again. First time that it happened with me. No problem. We open again. We go to the end of my presentation. End of presentation. Here. Then I'm going to skip this because we need to go. Then we release the third nerve. And then we are releasing the third nerve. If we remember, the superior cerebral artery is behind the third nerve because the posterior cerebral is superior. We leave we're opening the Meckel's cave, and what we see here, the third nerve, the fourth nerve, the fifth nerve, and the aneurysm. The aneurysm is just below the third nerve, okay? And then we can expose all the aneurysm through the basilar artery. What other kind of surgery can do this? No, the transcavernous, no. The classic transcavernous, you cannot see this. This portion you cannot see. But with the hemiplata, you can clip the aneurysm. You can trap the aneurysm. You can send the aneurysm to biopsy. Was a dissecting aneurysm, of course. And you can decompress the third nerve because this patient now is perfect without nothing. And then this is the IC green to show that the posterior cerebral artery is completely preserved. This is first CT angio that show the exclusion of the aneurysm. And finally, I will show you the late CT of the patient that show the patient is perfect only with a small infarction in the superior cerebral artery territory. And then this is the hemiplata concept. The hemiplata is get the posterior fossa using the cavernous sinus as your highway. And then again, we open. Now I'm just going to say my last words because I want to share with you something important. The important thing for me are my fellows. Without my fellows, I am nothing because them came with me with the best ideas. They came with me with all the hard work. They do the opening, the closure, and everything. I am very lucky to all the people that I teach. And now I'm going to share with you to finish that in the last year, in 2020, I was appointed as Master of the Chilean Neurosurgery. I am the fourth neurosurgeon that have this honor, the only alive. The last time was 24 years ago. Dr. Poblete, very famous pediatric neurosurgeon of my hospital, and even in the newspaper of my born city, they put me in the cover. For me, it was a huge honor. Now, 1 month ago, as appointed the president of the Chilean Neurosurgery Society, I'm very proud of that. And the last time we made a Latin American Congress in Chile was 1998, and in 2024 we will do again the Latin American Congress in my country, and you all are had a very warm invitation to this Latin American Congress in Chile. Thank you.
Dr. Llanos, do you want to comment? Are you there, Dr. Llanos? Okay, excelente. I wanted to get a neurosurgeon to comment on your talk.
Okay.
But I would like, Dr. Llanos, are you there?
Yeah, excellent talk by our friend Dr. Mura, and we appreciate your collaboration for this course, even though you couldn't make it. But It's been a great lecture. For us, this is the last talk for today. I don't know if you want to do some questions or something.
Yeah, yes. Besides the questions, Dr. Llanos, I'd like to invite both of you and anyone else. We have another Zoom immediately after this. We call it the Zoom Lounge, where the panelists get to meet you. It's a private Zoom. It's not televised, and it's not recorded. So right after this webinar, I put the link in the chat. Please copy that link. Okay, Jorge, you got that link? The students want to meet you, and they want to meet Dr. Llanos. Okay, you got that link, Dr. Llanos?
Let me check.
Okay, Margarita, do you got the link?
Let me check.
Okay. Let me put it in there again. And it's for any panelists also. Any panelists that want to come into this private Zoom are welcome.
Yeah, we got.
Because we're trying to make this a little more personal. And we're trying to increase the networking possibilities. Early reports are good.
We go out from this one now?
Yeah, not yet. Just hold on. Let me get the link. I'm going to put the link right now in the chat. It's worked well because we get to meet people. Because it's a people media. And I've done tons of Zooms and I don't see much interaction. Okay, copy that Zoom link. Don't go there now because you have to leave this before you go into that Zoom.
Ah, okay.
Yeah, you can't have two Zooms at once. So you got to leave this and go to that Zoom. Okay, you got that, Dr. Llanos? Do you have that link?
Yeah, we got the